This lecture is about the family Hepadnaviridae. The name comes from HEPA for hepatotropic and DNA from DNA genome. There are three types of viral particles that are visualized in infectious serum by electron microscopy, and you can see those pictured here. Two of the viral particles are smaller spherical structures with a diameter of 20 nanometers and filaments of variable lengths with a width of 22 nanometers. The spheres and filaments are composed of hepatitis B surface antigen and host-derived lipids without viral nucleic acids, and therefore they're non-infectious. The infectious HBV virion or Dane particle has a spherical double-shelled structure 42 nanometers in diameter, consisting of a lipid envelope containing hepatitis B surface antigen that surrounds an inner nucleocapsid composed of hepatitis B core antigen complexed with the virally encoded polymerase and the viral DNA genome. The genome of HBV is partially double-stranded circular DNA. The viral polymerase is covalently attached to the 5' end of the minus strand. So when you look at this, it's only the minus strand that's complete. The positive strand is incomplete. And here you can see an EM, you can see what the Dane particles and filaments and spheres look like. And you can see that filaments and spheres occur in abundance in positive serum. Now we need to talk about the replication cycle for hepatitis B virus. The virus infects only the liver due to the hepatocyte-specific expression of the HBV receptor, human sodium terephthalate cotransporting peptide, or NTCP. NTCP is expressed only on human hepatocytes. So mature HBV virions enter hepatocytes through the NTCP receptor on the cell membrane. The virion is endocytosed, then the nucleocapsid is released from the endosome by fusion of the virion and endosome membranes. The nucleocapsid is transported to the nucleus on a microtubule. And HBV capsids can pass through the nuclear pores. Okay, so the virus enters, it's uncoated, the nucleocapsid is released into the cytoplasm, then it's transported to the nucleus, and then the genome is released into the nucleus of the host cell. Now remember that that genome was a partially double-stranded duplex. The positive strand was not complete. Within the nucleus, the partially double-stranded DNA genome is filled up and converted to a covalently close circular DNA, or the CCC DNA. The episomal CCC DNA persists in the nucleus as a mini chromosome and is transcribed by cellular RNA polymerase II into the pregenomic RNA, or pgRNA, and the viral subgenomic, or SG, messenger RNAs. The viral RNA species are next exported to the cytoplasm, where viral protein synthesis takes place. The formation of progeny virions begins with the assembly of the icosahedral nucleocapsid that selectively incorporates the viral pgRNA together with the viral polymerase that is covalently linked to the pgRNA through its terminal protein, or TP, domain. So remember, the pgRNA is the full-length RNA copy. And then we had subgenomic RNAs that were also produced from transcription of the cccDNA inside the nucleus. The icosahedral nucleocapsid is built up by 240 copies of the single core protein. The core protein contains two separate domains: the N-terminal assembly domain, which is required to form the capsid shell, and the highly basic C-terminal domain, which is essential for viral replication and mediates the pgRNA/RT encapsidation. Inside the maturing nucleocapsid, the RT domain of the viral polymerase reverse transcribes the pgRNA to the double-stranded DNA genome through an RNA-DNA hybrid intermediate. Simultaneously, the RNA of the hybrid is degraded by the RNase-H domain of the viral polymerase. Mature progeny nucleocapsids are then enclosed by the viral envelope composed of host-derived lipids and three related viral glycoproteins, the small, middle, and large envelope proteins that are synthesized at the endoplasmic reticulum membrane. Okay, so let's look more closely at the replication of the viral genome. It happens inside the nucleocapsid, and you have P initiating reverse transcription, so the polymerase. It extends the negative sense DNA just a few nucleotides. It uses that hairpin structure to prime it. And then it has to shift to the 3' end to continue elongation because essentially it's run out of template. The pgRNA, that's the template. That's what you see up there at number 1. The pgRNA is degraded during transcription by RNase activity of the polymerase. This leaves an RNA oligomer that is translocated to the other end of the template. That primes the positive sense DNA synthesis. Then the molecule can circularize and the positive strand extends for a variable length. So when you have virus particles that are being released from host cells, they're going on to infect other host cells. Remember, inside that capsid, the DNA negative strand is complete, but the positive strand is incomplete. That strand is only completed once the virus has infected a host cell and the genome has been released into the nucleus of that host cell. During the positive strand synthesis, a nucleocapsid can either migrate to the nucleus to increase the pool of cccDNA, or it can undergo a maturation event that enables it to bud through a membrane containing virus envelope proteins. DNA synthesis ceases on budding as the nucleocapsid is cut off from the pool of nucleotides in the cytoplasm. So that explains why the positive strand DNA in the virion is incomplete. It won't be completed then until it's released into the nucleus of the new host cell. And so here you can see the entire replication cycle. So the key points, remember, genome replication involves synthesis of RNA in the nucleus, then copying RNA to DNA, so you have reverse transcription in the capsids. Stages in virion assembly include capsid construction and acquisition of the envelope by budding. HBV infection remains a major public health problem. About 2 billion individuals have been infected, representing approximately 30% of the world's population, and more than 250 million remain chronically infected and have a high risk to develop cirrhosis and hepatocellular carcinoma, or HCC. Despite the availability and usage of an efficient prophylactic vaccine, HBV infections continue to be an important health issue, as current therapeutics cannot cure chronic infections. Notably, HBV does not directly kill the infected liver cell, as progeny virions are released in a non-lytic manner. Instead, much of its pathogenesis is related to immune responses of the host and to its genotoxic and oncogenic potential. So you can see it's a huge problem. We don't have therapeutics to cure it, but there's an excellent vaccine. There's really no reason for people not to receive the vaccine if it's available to them. Reported cases of acute hepatitis B declined after routine vaccination of children was recommended in 1991 and became relatively stable from 2010 through 2018. In 2018, a total of 3,322 acute hepatitis B cases were reported to CDC, resulting in over 21,000 estimated infections. After adjusting for case under ascertainment and under reporting, the reported case count corresponded to a rate of 1.0 cases per 100,000 population. Over half of acute hepatitis B cases reported to CDC in 2018 occurred among persons aged 30 to 49 years old. Among the 1,500 reported acute cases that included risk information for drug use, about 36% reported injection drug use. A total of almost 15,000 case patients with acute hepatitis B were hospitalized. So that's about a 62% hospitalization rate amongst those for whom the hospitalization information was complete. Remember that the data that CDC gets is coming from all different health districts and things around the country, and not every case comes with a complete set of data. Data from death certificates filed in the Vital Records offices of the 50 states and District of Columbia found that the age-adjusted death rate associated with hepatitis B in 2018 among U.S. residents was 0.43 deaths per 100,000 population, which decreased only slightly from the 0.46 deaths per 100,000 population in 2017. Among 28 jurisdictions with data available, hepatitis B-associated death rates increased in 11 jurisdictions from 2017 to 2018. Rates of acute hepatitis B remain low in children and adolescents, most likely due to the childhood vaccinations. However, over half of acute hepatitis B cases reported to CDC in 2018 were in the age group of 30 to 49 years old. So even here in the U.S., where most people have pretty easy access to a good vaccine, we still have an awful lot of cases. But the fact that the vaccine is now given as part of the childhood vaccinations, we're seeing that it's mainly occurring in somewhat older age groups. The incubation period for hepatitis B is usually around 60 to 90 days, and the onset of acute disease is generally insidious. Clinical illness associated with acute infection is age-dependent. We see jaundice occurring in less than 10% of children infected under 5 years of age. And it jumps up to 30 to 50% of older children and adults. The case fatality rate for reported acute cases in the United States is approximately 0.5 to 1%. Most acute HBV infections in adults results in complete recovery with clearance of hepatitis B surface antigen from the blood and the production of anti-hepatitis B surface antibodies, designating immunity from future infection. However, approximately 30 to 90% of young children and 2 to 10% of adults who are infected with hepatitis B develop chronic infection, and most of the serious sequelae associated with hepatitis B virus occurs in these people. Persons with chronic hepatitis B infection are often asymptomatic, but these persons are at high risk for developing chronic hepatitis, and approximately 15 to 25% may die prematurely from either cirrhosis or liver cancer. The host hepatocyte is not killed directly by the HBV infection. The cell may survive for many months, releasing large quantities of virions and non-infectious particles. When the liver becomes damaged in an HBV-infected individual, it's not as a result of cell damage caused by the virus, but it's due to the killing of HBV-infected cells by the body's immune system. HBV is transmitted through activities that involve percutaneous, or puncture through the skin, or mucosal contact with infectious blood or bodily fluids, including semen and saliva. In the United States, probably the most important route of HBV transmission is by sexual contact, either heterosexual or homosexual, with an infected person. Direct parenteral inoculation of HBV by needles during injecting drug use is also an important mode of transmission. Transmission of HBV may also occur by other percutaneous exposures, including tattooing, ear piercings, and acupuncture, and by needle sticks or other injuries from sharp instruments sustained by medical personnel. However, these exposures account for only a small proportion of reported cases in the United States. In addition, transmission can occur perinatally from a chronically infected mother to her infant, most commonly by contact of maternal blood to the infant's mucous membranes at the time of delivery. So, as explained in the previous slide, HBV is transmitted by percutaneous or permucosal exposure to infectious blood or body fluids from persons who have either acute or chronic hepatitis B infection. The highest concentrations of virus are in blood and serous fluids. Lower concentrations are found in semen, vaginal fluid, and saliva. Therefore, blood exposure and sex contact are relatively efficient modes of transmission. Saliva can be a vehicle of transmission through bites. However, transmission has not been documented to occur as a result of other types of exposure to saliva, including kissing. Hepatitis B surface antigen has also been detected in low concentrations in other bodily fluids, including tears, sweat, urine, feces, breast milk, cerebrospinal fluid, and synovial fluid. However, these fluids have not been associated with transmission. HBV can survive outside the body for at least 7 days and still be capable of causing infection. So who is at risk? Well, based on the methods of transmission that we've already talked about, it just makes sense. It's infants born to infected mothers, individuals having sex with infected people, men who have sex with men are especially at a high risk, injection drug users, if you're a household contact or sexual partner of anyone with chronic hepatitis B infection. If you're a healthcare or public safety worker, you might have an occupational risk, and hemodialysis patients have a risk. Now let's look at the typical serological course when somebody's been infected with hepatitis B. So remember, most people infected with hepatitis B have an acute infection, and that's what we're going to look at first. The first serologic marker to appear following acute infection is the hepatitis B surface antigen that can be detected as early as 1 or 2 weeks and as late as 11 or 12 weeks after exposure to hepatitis B. In persons who recover, hepatitis B surface antigen is no longer detectable in serum after an average period of about 3 months. Hepatitis E antigen is generally detectable in patients with acute infection. The presence of the hepatitis E antigen in serum correlates with higher titers of hepatitis B virus and greater infectivity. A diagnosis of acute hepatitis B infection can be made on the basis of the detection of IgM class antibody to hepatitis B core antigen in the serum. IgM anti-core antibodies are generally detectable at the time of clinical onset and decline to subdetectable levels within 6 months. IgG anti-core antibodies persist indefinitely as a marker of past infection. Anti-hepatitis B surface antigen becomes detectable during convalescence after the disappearance of hepatitis surface antigen in patients who do not progress to chronic infection. The presence of anti-hepatitis B surface antigens following acute infection generally indicates recovery and immunity from reinfection. So this is the pattern when somebody has an acute infection that they clear, and then from that point on, they're going to be immune if they're exposed again. But remember, in a percent of people, they go on to develop a chronic infection. In patients with chronic hepatitis B infection, both hepatitis B surface antigen and IgG anti-hepatitis B core remain persistently detectable, generally for life. Hepatitis B E antigen is variably present in these patients. The presence of hepatitis surface antigen for 6 months or more is generally indicative of chronic infection. In addition, a negative test for IgM anti-hepatitis C, or the core antigen, together with a positive test for the surface antigen in a single serum specimen usually indicates that an individual has chronic hepatitis B infection. So these are individuals who are going to remain infected for life. They're at risk of developing other kinds of problems, and they're not going to clear this infection. The outcome of acute hepatitis B infection varies substantially depending on the age at which infection occurs. In children less than 5 years of age, less than 5% of acute hepatitis B infections are symptomatic. However, chronic infection occurs in about 80 to 90% of infants infected during the first year of life, and 30 to 50% of children infected between 1 and 4 years of age. In comparison, 30 to 50% of adults with acute hepatitis B infection are symptomatic, but only 2 to 10% develop chronic infection. So you can see how these two lines cross. Chronic infection would be the green line. The symptomatic infections are the blue lines. So the older the patient, the greater the percent of patients that will have a symptomatic infection. But the older the patient, the less likely they are to develop a chronic infection. Hepatocellular carcinoma, or HCC, is the fifth most common cancer in men and the second leading cause of cancer deaths globally. The high prevalence of HCC is due in part to the high prevalence of chronic hepatitis B virus infection and the high mortality rate due to the lack of biomarkers for early detection and the limited treatment options for late-stage HCC. So again, we've got hundreds of thousands of deaths per year, and it's more common in men, but it's associated with chronic hepatitis B, and it appears in people after being infected for years. In this individual, you see a young woman, she's only in her late 20s, but had been infected with hepatitis B as a child. And you can see how distended her abdomen is from her liver cancer. Sadly, she died within just a week or so of this picture having been taken. The strategy to eliminate hepatitis B in the United States includes several components. First, you want to prevent perinatal hepatitis B transmission by screening all pregnant women for hepatitis B surface antigen. And any woman who tests positive for this, you want to provide hepatitis B immune globulin, or HBIG, to the woman and give the infant the hepatitis B vaccine as soon as possible after birth. Next, you want to provide routine hepatitis B vaccination to all infants as part of the routine childhood vaccination schedule. Then there's a special effort to provide catch-up vaccination for children in high-risk groups, including Alaska Natives, Pacific Islanders, and infants of immigrants from countries with a high prevalence of chronic hepatitis B infection. You want to provide hepatitis B vaccine to adolescents, including those who were previously unvaccinated, and adolescents of any age who are at high risk for infection. And then vaccinating adults in high-risk groups that include men and women with a history of sexually transmitted diseases and people who are recipients of clotting factor concentrates. Since the hepatitis B vaccine was licensed for use in the United States in 1981, the incidence of acute hepatitis B has changed dramatically. During the 1980s, the use of hepatitis B vaccine had little effect on disease incidence, which actually increased during the 1980s. The incidence declined between 1985 and 1988, and between 1988 and 1991, when fewer cases were reported among homosexual men and among injecting drug users, respectively. In both of these groups, the decline in incidence was likely related to behavioral changes in response to the epidemic of acquired immunodeficiency syndrome, or AIDS, HIV, rather than to vaccine use. The incidence has continued to decline during the first half of the 1990s. A likely contributing factor for this most recent decline is the widespread use of hepatitis B vaccine in response to regulations issued by Occupational Safety and Health Administration. Future declines in incidence are expected to occur as a result of the implementation of routine infant and routine adolescent vaccination, which was recommended in the 1990s. So after OSHA made its rule, we started seeing much more widespread vaccination of people in the workforce who had an occupational risk for hepatitis B. Because when the vaccine first came out, you had to get 3 doses, and it was quite expensive, and individuals had to pay for it themselves. So a lot of people who would have benefited from the vaccine either chose not to invest in it or couldn't afford it. This slide summarizes the healthcare-associated outbreaks of hepatitis B virus infection that was reported in the United States during 2008 to 2019. Because of the long incubation period, which can be up to 6 months, and a typically asymptomatic course of acute hepatitis B infection, it's likely that only a fraction of such outbreaks that occurred have been detected, and reporting of outbreaks detected and investigated by state and local health departments is not required. Therefore, the numbers reported here greatly underestimate the number of outbreak-associated cases and the number of at-risk persons notified for screening. However, you can see some interesting things. The majority of outbreaks occurred in long-term care facilities, and of those, almost 80% were associated with the monitoring of blood glucose. With an elderly population in a long-term care facility, many people have diabetes, and that requires frequent blood testing. And if there's a breakdown in how that testing is done, it's a good way to transmit hepatitis B. Virions of HDV are approximately spherical with an average diameter of about 40 nanometers. They lack visible surface projections. They have an outer envelope containing lipid and all 3 envelope proteins of the co-infecting helper virus HBV. The HDV encoded protein, known as HDAG or HD antigen, exists in 2 forms, a small and a large. The HD virion has an inner ribonucleoprotein comprising approximately 70 copies of variable amounts of the small and the large antigen in close association with HDV RNA. Nucleocapsid symmetry has not been determined. Since hepatitis D virus is a defective virus and does not code for its own surface proteins, it depends on the surface proteins of the helper HBV to form its own envelope and for egress and re-entry into hepatocytes. HDV prevalence is highly different among different countries. The most prevalent areas are Punjab, the Amazon basin, Somalia, and Mongolia. In European countries, the highest prevalences are seen in Romania and Albania. HDV entry is modulated by the hepatitis B surface proteins in its envelope, and of course it has to use the same receptors as hepatitis B virus. The viral RNP is then transported to the nucleus where it releases the viral genome that serves as template to transcription of HDV messenger RNA, from which the HDV antigens are translated. Replication of viral RNA is mediated by cellular DNA-dependent RNA polymerases through a rolling circle mechanism. The newly formed HDV RNPs are assembled in the nucleus, exported, and then enveloped by hepatitis B surface glycoproteins. Hepatitis D virions are thought to be secreted through the Golgi in parallel with the hepatitis B subviral particles. So within the hepatocyte, replication leads to the accumulation of 3 different hepatitis D viral RNAs. You have the circular genomic RNA, you have the antigenomic RNA, and a smaller linear messenger RNA. This linear messenger RNA is a template for the translation of the hepatitis D antigen proteins. HDV uses a rolling circle amplification mechanism and the host RNA polymerase II to transform the genomic hepatitis D virus RNA into its exact complementary form, the antigenomic hepatitis D RNA, and then into new viral genomes. Hepatitis B plays an essential role as a helper virus for hepatitis D, since its envelope proteins are stringently necessary for the propagation of hepatitis D virus. Therefore, the release of hepatitis delta virions from the infected hepatocytes can occur only if the cells are co-infected with hepatitis B, or when hepatitis D virus superinfection occurs in individuals already infected with hepatitis B. In infected cells, the HDV genome replication and formation of the nucleocapsid-like ribonucleoprotein, or the RNP, are independent of hepatitis B virus. But the RNP cannot exit and therefore propagate in the absence of hepatitis B, as the latter supplies the propagation mechanism from coating the HDV RNP with the HBV envelope proteins for cell egress to delivery of the HDV virions to the human hepatocyte target. HDV is therefore an obligate satellite of hepatitis B. The modes of hepatitis delta transmission are similar to those for hepatitis B, with percutaneous exposures being the most efficient. Sexual transmission of hepatitis delta is less efficient than it is for hepatitis B. Perinatal HDV transmission is rare. HDV can be transmitted by blood and blood-derived products and sexual contact. Vertical transmission is, however, rare. In highly endemic populations, transmission occurs mainly through intrafamilial and iatrogenic spread in association with poor hygiene conditions. In low endemicity regions in the northern hemisphere, the most common route of hepatitis D virus infection now is through intravenous drug use. Sexual transmission, although less frequent than what we see for hepatitis B or HIV, appears to be important in regions where hepatitis B infection is endemic. Hepatitis D infection can be acquired either as a co-infection with hepatitis B or as a superinfection of persons with chronic hepatitis B. Persons with a Hep B, Hep D co-infection may have more severe acute disease and a higher risk of fulminant hepatitis compared to those infected with Hep B alone. However, chronic Hep B infection appears to occur less frequently in people who were co-infected. Chronic hepatitis B carriers who acquire Hep D superinfection usually develop chronic hepatitis D infection. Long-term studies of chronic Hep B carriers with Hep D superinfection have shown that 70 to 80% developed evidence of chronic liver diseases with cirrhosis compared to 15 to 30% of patients with just hepatitis B chronic infection alone. So the presence of the helper has a strong impact on the clinical features of the disease, and it matters as to whether or not it's a co-infection or a superinfection. So let's look at the serological course of these two modes of infection. So first, let's look at co-infection. In most persons with a co-infection, both IgM antibody to Hep D or anti-HDV and IgG hepatitis D virus are detectable during the course of infection. However, in about 15% of patients, the only evidence of hepatitis delta infection may be the detection of either IgM anti-HDV alone during the early acute phase of illness or IgG anti-HDV alone during convalescence. Anti-HDV generally declines to subdetectable levels after the infection resolves, and there is no serological marker that persists to indicate that the patient was ever infected with hepatitis D. HD antigen can be detected in serum in only about 25% of patients with the co-infection. When HD antigen is detectable, it generally disappears as hepatitis B surface antigen disappears, and most patients do not develop chronic infections. Tests for IgG anti-HDV are commercially available in the United States. Tests for IgM anti-HDV, HDAG, and HDV RNA by PCR are only available in research laboratories. In patients with chronic hepatitis B infection who are superinfected with hepatitis D, several characteristic serological features generally occur, including the titer of hepatitis B surface antigen declines at the time the hepatitis D antigen appears in the serum. The hepatitis D antigen and the hepatitis D RNA remain detectable in the serum because chronic hepatitis D infection generally occurs in most patients with the superinfection, unlike the case with co-infections. And you get high titers of both IgM and IgG anti-HDV, which are detectable and persist indefinitely. So, very different clinical pictures depending on whether you have a co-infection or a superinfection, and as you would expect then, the serological course is very different. And with superinfection, you're able to detect the hepatitis D RNA and the hepatitis B surface antigens indefinitely. Okay, so key facts about hepatitis D. Remember, it's a defective virus. It needs its helper, hepatitis B, in order to replicate and propagate. Hepatitis D has a strong impact on the disease profile, and it depends on whether or not you had superinfection or co-infection, but it can accelerate the progression to cirrhosis and increase the risk of hepatocellular cancer in patients with hepatitis B virus. And it enhances hepatitis B related oncogenesis, thought to occur through pathways related to inflammation and fibrosis. Okay, in terms of prevention and control, because hepatitis D virus is dependent on its helper, hepatitis B, for replication, hepatitis co-infections can be prevented with either pre or post-exposure prophylaxis for hepatitis B. However, no products exist to prevent hepatitis D superinfections of persons with chronic hepatitis B infection. Thus, prevention of hepatitis D superinfection depends primarily on education to reduce risk factors.